Laboratory diagnosis of kidney diseases. What are the function of the kidneys? Basically, the function is as filtering the blood, removing the metabolic product and the toxins from the blood and excreting them through the urine. Also regulate the bloody fluid status, electrolyte balance and acid-base balance, and produces or activate hormones and involved in erythropoiesis by synthesizing erythropoietin and calcium metabolism as well. Plus, it regulates the blood pressure and the blood flow. When we are testing the function of the kidney, basically the renal function may be assessed by measuring blood urea and serum creatinine. The renal function, however, decreases by age, which must be taken into account when interpret the results. The test primarily evaluate the glomerular function by assessing the glomerular filtration. In many renal diseases, urea and creatinine accumulate in the blood because they are not excreted properly. These tests also aid to determining drug dosage for drug excreted through the kidneys. The renal function tests. The renal function tests are used to detect the presence of the renal diseases and assess their progression. The tests give information about the blood flow, GFR, renal glomerular function, renal tubular function, and the urinary output. So any of this usually is involved in the renal function. So any changes could occur and you can somehow conclude the renal function. Now, what can we evaluate to test the kidney failure? First of all, there are two sides of the kidney. One is the urine that is produced, and another one is the blood. In the urine, we can test the volume, color, sediment, glucose, bilirubin, ketone bodies, density, hemoglobin, sodium, potassium, chloride, and so on. While in the blood, we can measure the creatinine, urea, ammonium, uric acid, sodium, potassium, chloride, protein, albumin, cystatin C, pH, and so on, and some uh, hormones as well. Also, we can do some functional analysis, imaging techniques, and take biopsies. The physical characteristic of urine. Let's start with the urine measurement. The normal urine volume is about 1 to 1.5 liters per day. If we have more than 2 liters, we talk about polyuria. If it's less than 500 ml per day, that's oliguria. If we consider the maximum concentration capability of the kidney, that meaning the waste product that produced by day, it can be excreted in 500 ml. However, if the volume is less, you do have a continuous accumulation of the waste product. Anuria, usually the patient doesn't void urine spontaneously, and that's less than 200 ml per day. For sure, we do have an accumulation of the waste product in our blood. The color and transparency. It's clear, pale to deep yellow depending on the hydration. This is due to the urochrome. The concentrated urine has a deeper yellow amber color. Red or red-brown abnormal color could be from the food dye, eating fresh beets and drugs, or presence of either hemoglobin or myoglobin. If the sample contained many red blood cells, it would be cloudy as well as red. Turbidity or cloudiness may be caused by excessive cellular material or protein in the urine. The physical characteristic, such as the odor, usually the fresh urine is slightly aromatic. Standing urine develops an ammonia odor. Some drugs and vegetables, such as asparagus, alter the usual odor. Ketone bodies gives a smell of fruit or acetol-like. There's gravity. The gravity is measures the density of the urine compared to water. The range is from almost the water is 1000 to 1035. The 1000 that is close to water when the kidney dilute, and the 1035 is the most concentrated one. Expressed in osmolality, the 1001 is close to, let's say, maybe 10 milliosmol, while 1035 is about 1200 milliosmol. Now, the specific gravity is depending on the solute concentration. 1035 is either contaminating a very high level of glucose or very concentrated the urine, and this is when we do have a very low water intake. The chemical composition of the urine, basically it's a 95% is water and about 5% is only the solute material. Nitrogenous waste products such as urea, uric acid, and creatinine, and other normal substances such as sodium, potassium, phosphate, and sulfate ions, calcium, magnesium, and bicarbonate ion. An abnormally high concentration of any urinary contents may indicate pathophysiological condition. How do we measure the urine containing? Usually we are using the dipstick method. These are chemical reaction that causes color changes on the different pads on the test tips. We do have, let's see, 10 little pads on the strip that is sensitive to leukocytes, nitrite, urobilinogen, protein, pH, blood, ketone bodies, and glucose as well. We do use, let's say, an instrument that making and reading the color, and this is how we give the diagnosis. Hematuria. If you do have blood in the urine, is always indicative pathology because the red blood cells is too large to pass through the glomerulus. Possible cause is a microscopic hematuria, usually occurs coloring the urine to the red, that meaning about 1 ml blood per 1 liter of urine. Now that can be due to kidney stone, for example, infection or tumor. And however, you have to know that it's very common finding in women because of menstruation. And here you can see the pads when we talk about a negative value, trace, and about 50 or about 200 erythrocytes per microliter. And the hemoglobin values is in this other green pads here. The urine pH changing with a very wide range, from 4.5 to the very acidic one to 8.2 to the alkalic one. The average is around 6. The pH should be recorded, however, it almost has no clinical diagnostic value. The diet altering the pH very much. The acidic pH can be recorded when we do have a very high protein diet or in ketoacidosis. The alkaline pH can be obtained in vegetarians or urinary tract infection. Protein in the urine. Usually protein are too large to pass through the glomerulus. Proteinuria usually represents an abnormality in the glomeruli filtration barrier. The normal value is about 50 to 100 milligram per day. So we do have a small amount of protein in the urine. The mild, it can range from 300 to 500 milligram per day, while the moderate one is up to 2 grams per day. The severe one usually is over 2 grams per day. Here you can see what the plus, 2 plus or 3 plus means in concentration. The trace amounts of normal in pregnancy or after eating a lot of protein. Albuminuria, when the albumin concentration in the urine is higher, selectively higher than 150 milligram per day. Microalbuminuria, we talk about when it's ranging between 50 and 100 milligram per day. That can an indicative of the glomerular damage. Because of the protein concentration is depending on the hydration status, this is why the protein excretion should be normalized. The daily protein excretion usually is determined by from the 24 hours collected urine. However, it is associated with some difficulties such as the patient adherence and the adequate collection and handling of the material in the laboratory. It's very difficult, for example, in children to collect or measure the normal urine volume. Nevertheless, random measurement cannot be taken due to the great variation of the concentration of the urinary protein throughout the day. This is why they normalize the urine protein concentration to the creatinine. The, this is called the spot urine creatinine test and is expressed by milligram protein by millimole creatinine. The normal value when the total protein ratio is less than 50 milligram per millimole. And very similarly, we can apply to albumin as well when we do have an albumin creatinine ratio, the ARC, that is usually is less than 30 milligram per millimole. And we talk about microalbuminuria when it's bigger than 30 milligram per millimole. The UBG, urobilinogen, in the urine that when we tested the liver function, we mentioned that urobilinogen is formed in the intestine, and that reflects the normal passage from the to the bile to the intestine, and that should be normally occurring in the urine. Absence that can mean that we do have a renal diseases or we do have a biliary tract obstruction. An increased urobilinogen could mean that increases the production or retention of the bilirubin, such as happening in hepatitis or cirrhosis or biliary diseases. Nitrate in the urine. It might indicate bacterial infection with a gram-negative routes like E. coli. The bacteria presence, they convert the nitrates to nitrate. Normally, it should be negative. Leukocytes in the urine that indicative of inflammation. Normally is negative. If you do have leukocytes in the urine, that could mean pyuria. If we do have bladder infection, such as cystitis or pyelonephritis in kidney infection, all indicated by the presence of the leukocytes in the urine. Urine sediments. If a urine sample is centrifuged, the sediment can be viewed microscopically to examine the solid components. Some solids are normally found in the urine. That can be performed manually by microscope or automated sediment analysis. The manual urine sediment analysis, when we do have, this is a commercial slide system, so that provides some standardization, technique dependent, varying concentration ratio, addition of the drop of stain, also varies concentration of ratio, low and high power fields of view are microscope dependent, reporting units inadequacy. So this is the limitation of the manual sediment analysis. The benefits of automated urine microscopy, relatively it's very fast. It reduces the subjective identification of the element and this very low grade of the technician variability, improve the accuracy and reproducibility, and the workflow is very fast and relatively is cheaper. Now, when we look at the urine sediments, now we are using, let's see, the microscopic pictures as well, but this can be identified by the instruments. Now let's see the cells. What kind of cells you can see in the sediment? A small number of epithelial cells that are shed from the various region of the urinary tract or larger number of the white blood cells and any amount of red blood cells are abnormal, usually indicate some diseases here and bacteria, white blood cells, this the picture is showing. Organism in the urine. Some organisms commonly found in the urine, some yeast, Trichomonas vaginalis, or common protozoans infection, a Candida albicans vaginal yeast infection that also can be found in the sediment. Microscopic examination, pyuria. when we do have white blood cells in the urine. Normally, we do have in men about less than 2 white blood cells per in high power field, in women less than 5. The white blood cells generally indicate the presence of an inflammatory process somewhere around the course of the urinary tract. Look at pictures, you can see the granulocytes here. Hematuria, red blood cells in the urine. The red blood cells may appear normally shaped, swollen by diluted urine, or created by concentrated urine, some spiky-like. The presence of the dysmorphic, odd-shaped red blood cells in the urine suggests the glomerular disease when the red blood cells passing through to the tubular system and passing through the different osmolality as well. So this is why they are going to be dysmorphic. And that indicates glomerulonephritis. These are the dysmorphic red blood cells. Epithelial cells. Transitional epithelial cells originate from the renal pelvis, ureters, and bladder or the urethra. If there are squamous epithelial cells in your urine, it may mean your sample was contaminated. This meaning that the samples contain cells from the urethra in men or the vagina opening in women. It can happen if you do not clean well enough when using the clean catch method. Large sheets of transition epithelial cells can be seen in bladder cancer. Casts. The cast is a hardened cell fragments formed in the distal convoluted tubules and collecting ducts, from where cells clump together. Usually form when urine is acidic or contains high level of proteins or salt, usually pathological, can only be seen with microscopic examination. White blood cell cast usually indicates pyelonephritis, kidney infection. The other case can be interstitial nephritis, inflammation of the tubules and the space between the tubules and the glomeruli. Red blood cell cast formed in the tubular cells, and that could indicate glomerulonephritis with leakage of the red blood cells from the glomeruli, or very severe hyaline cast composed primarily of a uroprotein. It's called the Tom Horsfall protein secreted by the tubular cells. The cause is when the flow rate is very low, or we do have a very high salt concentration and very low pH, all of which favor protein denaturation and precipitation of the Tom Horse protein. Calcium oxalate crystals. They can occur in the urine of any pH, usually is due to the dietary, for example, asparagus or ethylene glycol intoxication. Uric acid crystals. High uric acids in the blood byproduct of the pre-urine digestion, high protein diet, it could be associated with gut arthritis. Stuvite crystal. Stuvite crystal is a magnesium ammonium phosphate salt. The formation is promoted by alkalic urine. In urinary tract infection, especially when the bacteria is the Proteus vulgaris that promotes the ammonium formation, the stuvite crystal formation increased. Serum creatinine level. Creatinine is the product of the muscle energy metabolism and produced at a constant rate according to the muscle mass of the individual. It is the substance that is easily excreted by the kidney. The serum creatinine is a very good indicator of the glomerular function. Creatinine also can be measured in the urine as well. The interpretation of the high creatinine usually is connected to the GFR, the glomerular filtration rate, when it's decreased. This situation can happen in acute or chronic kidney diseases, ureter obstruction, in dehydration, and glomerulonephritis. Looking at this graph, you can see that the serum level of the creatinine and the kidney function, this is Hungarian, but normal Wäschefunktion is kidney function. And you can see that the normal level of the creatinine, that is less than 90 or 100 micromole per liter, is only exceeded when the kidney function is deteriorated very much. So if you see that the GFR is already decreased around 40 to 30 milliliter per minute, that normally is 125. So we lost about 70–80% of the kidney function or the GFR function. So the patient has a kidney failure or pre-uremic stages. So this is why serum creatinine itself, it cannot be used to detect the kidney failure. Cystatin C, that's a 30 kilodalton protease inhibitor that's constantly produced by all nucleated cells. The advantage over the creatinine is by the concentrate production, freely filtrated glomeruli, unaffected by the muscle mass, diet, or gender, no renal tubular secretion, good assay precision is at about 3% of the variation between assays, and unaffected by the spectral interference. However, it's expensive. How can we determine the glomerular filtration rate? The GFR, that represents the clearance rate when any solution is freely filtrated and neither reabsorbed nor secreted by the kidney. The GFR is typically recorded in milliliter per minute and usually by the surface area in square meter, the rate at which the plasma is filtered by the kidney glomeruli. It's an important measurement in evaluation of the kidney function. As I mentioned before, the normal value is around 125 milliliter plasma per minute or 180 liters per day. The plasma volume in a 70 kilogram young adult is about 3 liters. So the kidney filters the plasma about 60 times a day. Now, what is the mechanism of the glomerular filtration? Usually, it's going to depend on the capillary permeability and the size of the capillary bed and the molecules and the charge. So a lot of things is going to alter the glomerular filtration. Usually this filtration occurs between the podocytes legs, and it's a fenestrated epithelial cells that is looking at the Bowman capsule. Now, what is going to affect this GFR? Change in renal blood flow, the glomerular capillary hydrostatic pressure, change in the capsular hydrostatic pressure, the oncotic pressure, glomerular capillary permeability, effective filtration surface area, the size, shape, and electrical charge of the macromolecules. This is a very complex mechanism. The creatinine clearance. The best way or the cheapest way to estimate the GFR is by measure or determine the creatinine clearance. Now, what they do, they're measuring the serum and the urine creatinine, and they calculate relatively how much blood is filtrated per minute, because the creatinine is filtrated, not reabsorbed, but know that about 10% is excreted. So when we do have a very low level of the GFR, creatinine clearance always overestimate the real GFR. So as you see here, what they do, they measure the urine concentration of the creatinine, they measure the volume of the urine, and they're measuring the concentration of the creatinine in the plasma. And they can calculate the serum creatinine. Now, What do we do and how do we use this? Now, GFR is not an easy to measure directly. So the serum creatinine is used the most time. However, relatively, it's very difficult to measure the real GFR level. The creatinine clearance is considered too inaccurate due to difficulties to obtain the correct timed specimen and measure the volume. This is why the guidelines recommend that the clinical labs report should use an estimated GFR using this MDRD prediction equation in addition to the serum creatinine. This is usually calculated from the serum creatinine value. Because the serum creatinine value is almost linearly changing when the patient has, let's say, in a normal range or up to when it's going to increase exponentially. And these variables that will affect the estimation of GFR, for example, age, sex, race, diet, body build, medication, or pregnancy. And variables are significant use of the creatinine clearance. Now, estimated GFR, this is an equation, and as you know that based on the muscle mass, in female you have 2 times with the lower value, and in black, because they do have more muscle mass, usually you times with a higher value. You can calculate very easily the eGFR. You can find this site where you punch the data, the serum creatinine value, and the sex and race and the height and the weight of the patient, and you can calculate directly. Serum uric acid is a naturally occurring waste product resulting from the breakdown of purine, crystalline compound found in certain foods. Under normal condition, uric acid dissolves in the blood, passes through the kidney, and eliminates with the urine. The use of serum uric acid. If you do have a high concentration of uric acid in the blood, it can indicate a lot of situations such as diabetes, gut, acute arthritis, chemotherapy, radiation, leukemia, hypoparathyroidism, kidney disorders such as stone, multiple myeloma, or metastatized cancer. In low level can be obtained in Wilson disease, Fanconi syndrome, in an alcoholic patient, liver or kidney diseases, and very low purine diets. Serum urea is the chief nitrogenous product of the protein metabolism. What can alter the serum urea level? If you do have, for example, some pre-renal causes such as dehydration due to severe vomiting, intestinal obstruction, diarrhea, diabetic coma, severe burns, fever, and severe infections. Some renal causes such as the acute glomerulonephritis, nephrosis, malignant hypertension, chronic pyelonephritis. And what else can decrease? Urea concentration of serum may be low in late pregnancy, in starvation, and diet grossly deficient in protein and in hepatic failure. Urea creatinine ratio. The rationale of the use of creatinine and urea measurement to assess renal function is that plasma serum level of both reflects glomerular filtration rate, the parameters that defines kidney function for the clinician. Both compounds are freely filtrated, but urea reuptake is increased in dehydrated patients while it is reduced in renal parenchymal damage. Pre-renal kidney failure, this ratio is 100 partial of urea and 1 partial of the creatinine, so it's 100 to 1. In parenchymal kidney failure, this ratio is less than 20 to 1. Azotemia is when we do have a nitrogen, creatinine, urea, uric acid, that is called a non-protein nitrogen-based product, increased in the blood, and that could be the hallmark of the kidney failure. Serum potassium. The function of the potassium is to maintain the proper electrical conduction in cardiac and skeletal muscle. Potassium measurements are used to monitor electrolyte balance in the diagnosis and the treatment of the disease condition characterized by the low or the high potassium level. The potassium level is regulated by kidneys, aldosterone, the endocrine system, arterial pH, insulin, potassium intake, and sodium delivery to the distal tubules. The interpretation. Hypokalemia. The kidney are responsible for approximately about 90% of the daily potassium loss. Other loss occur mainly through the GI system. A low potassium level has many causes but usually results from vomiting, diarrhea, adrenal gland disorders. A low potassium level can make muscles feel weak, cramp, twitch, or even become paralyzed, and abnormal heart rhythm may develop. Hyperkalemia, the most common results from the decreased renal elimination, excessive intake, or from cellular breakdown, such happening, for example, in cytotoxic therapy. So the potassium is a marker, a retention marker of the kidney function. Fractional excretion of the sodium. So the sodium is filtrated freely and reabsorbed depending on the need. If we make a ratio of the excreted sodium and the filtrated one, this is what it means. That's the fractional excretion of the sodium. So relatively, the filtrated sodium is considering the plasma sodium level and the GFR, so this can be calculated, while the excreted sodium is depending on the volume of the urine and the amount of urine volume. So the use of fractional excretion of the sodium. If the fractional excretion of the sodium is less than 1%, that could indicate a pre-renal disease caused acute kidney injury. And this is how we can distinguish that's the parenchymal damage and the pre-renal causes. However, it is applied only if the patient has a very much reduced GFR. So this is why there is no absolute value for the fractional excretion of the sodium that always dies. What could be the leading symptoms of the renal disease and what kind of lab measurement could be found? For example, microalbuminuria can be indicative of the diabetes or hypertension caused nephropathy. Another one, tubular microproteins that can indicate chronic ischemia, pain, for example, renal stones, hematuria, glomerulonephritis, Urea, pyelonephritis, or reduction of the GFR and increase of the retention parameters that indicate acute tubular necrosis and chronic or acute kidney diseases. We could use renal imaging techniques such as the ultrasound, that the size of the kidney can be indicative. For example, if it's a big one, it can indicate diabetes mellitus or amyloidosis. A small one, such as a chronic or renovascular renal diseases. Obstruction, polycystic kidney, Doppler ultrasound can be used to renovascular renal diseases or renal vein thrombosis. Isotope scan, renovascular renal diseases, obstruction. But you have to know that if somebody has a decreased renal function, the isotopes is not safe to use. CT can evaluate the kidney size and cyst formation. MRI, renovascular renal diseases. Angiography, renovascular renal diseases. Arteriorenal thrombosis. Retrograde ureterogram, upper urinary tract obstruction. IV pyelography, for example, for pyelonephritis, however, is contraindicative in renal failure. Based on the clinical syndromes or symptoms, we do have two major types of categories, such as the nephrotic syndrome or nephritic syndrome. However, because this is a sum of the clinical sign, The cause is very diverse. Let's see what the nephrotic syndrome is. The patient who has massive proteinuria, when we do have more than 3 grams per day urine protein excretion, and this is causing hypoproteinemia. Due to the decreased oncotic pressure, the patient presents as edema, generalized edema. And the possible causes when we do have some kind of altering of the filtration mechanism of the glomeruli, and this is the albumin, and the protein is lost through the glomeruli. Now, due to the hypoalbuminemia, the liver protein synthesis induces, and not only the albumin, but the lipoprotein synthesis increases, and more LDL found in the blood. But the LDL is a big molecule, so it is not excreted by the kidney. This is why hyperlipidemia is very common. In nephritic syndrome, the leading symptoms is hematuria, mostly as microscopic hematuria, and red blood cells is dysmorphic, so they are altered the shape. Another one, because the GFR is shutting down, the kidney failure, azotemia occurs, oligoanuria, nitrogen retention, very high level of the serum creatinine and urea. And there are signs of systemic inflammation, and very common, the hypertension can occur. If we look at the sediments, in nephritic syndrome, we do have red blood cell cast, while in nephrotic syndrome, hyaline cast can be found in the sediment.